welcome
Yeah.
presentation.
Thank you. Good afternoon, colleagues. My name is Andri. I come from Indonesia. I am basically a psychiatric working in the outpatient clinic since 2008, and in my daily work I see around 15 to 20 patients per day, 6 days a week from Monday to Saturday, and more than 75% of these patients present with anxiety disorder, somatic symptom disorder, or psychosomatic condition. And it is therefore a privilege to share with you today my presentation. And this is my third WASAT, 2019, 2023, and this is 2025. I'm very happy and honored to be here. And I will talk about evidence versus efficacy, like Professor Goldstead said, that real-world outcomes of anxiety treatment in resource-limited settings. This talk will reflect both research and over 15 years of clinical experience in managing patients whose anxiety manifests predominantly through the body. So this is a little bit about my background. So I know that in psychiatry, international guidelines are critical. We know this is very important, but they often fall short of addressing the first presentation in resource-limited contexts. And the real-world outcomes remind us three things. First, the need to bridge the gap between guidelines and local realities. The second, the importance of patient-centered care. The treatments must be effective in the life experience of our patients. And third, the ethical imperative to make culturally sensitive and pragmatic clinical decisions. So the challenge is in many low-income countries like Indonesia and also in many Asian, especially Southeast Asian countries, psychiatrists frequently encounter anxiety disorders not as symptoms like fear or worry. Patients may complain of chest tightness, they complain also the persistent headache or gastrointestinal discomfort. So this somatic dominance creates a diagnostic challenge and complicates treatments, especially when psychotherapy is difficult to access. So I come with three case studies. The first one is the 45-year-old woman who presented with severe palpitations and chest pressure. She had minimal response to SSRIs as monotherapy because he's already been diagnosed with a generalized anxiety disorder. And after introducing a low-dose clonazepam, her symptoms improved rapidly and her daily functioning was restored. So this case demonstrates the value of pragmatic adaptation to clinical realities by using a small dose of clonazepam as benzodiazepine. The second case, a 32-year-old man presented with chronic nausea and stomach pain, unresponsive to gastrointestinal therapy. So the gastrointestinal specialist sent this patient to me. When he was in the clinic, his anxiety symptoms were very robust, and we treated by sertraline before seeing me, and I added a low-dose alprazolam and sulpirate, resulted in marked improvement, enabling him to resume work and social functioning. And here again, a flexible approach provided a meaningful relief. Our third case is a 50-year-old woman suffering from daily headaches and disabling dizziness. He has been on SSRI but had little effect, and the introduction of low-dose diazepam led to a significant reduction in both frequency and intensity of her symptoms. This allows her to participate in rehabilitations and eventually reduce the benzodiazepine use. This case also illustrates how judicious time-limited benzodiazepines use can play a bridging role. So we know from the guidelines, the recommendations for GAD and panic disorder is both psychotherapy and pharmacotherapy. The first line is the SSRI and the SNRI. And if we see the international guidelines, many from the British Association of Psychiatry, from NICE guideline, CANMET, Royal College of Australian and New Zealand's Psychiatry, and World Federations of Biological Psychiatry, only one that proposed benzodiazepine has been shown to be efficacious also to treat the patients with anxiety. So the common pattern is when anxiety presents through the body, antidepressants alone may not be enough sometimes, especially when psychotherapy access is limited. So I want to show this slide, presents finding from a large meta-analysis of 234 randomized control trial, including over 37,000 patients with generalized anxiety disorder, panic disorder, and social anxiety disorder. The key message here is that pharmacological treatment tend to show stronger effects than psychotherapies when outcomes are pooled. But looking at the blue bars, we see that SSRI and SNRIs are, some comparisons are slightly higher, and then both are very effective to treat the anxiety. But I want to show this also, this kind of like a benzodiazepine use also have shown effect size around 2.15, and this is comparable also to the SSRI and SNRIs, and in some comparison even slightly higher. And this supports what many of us see in daily practice. Benzodiazepine can bring rapid and meaningful relief. I know that there is some afraid of physicians to use the benzodiazepines because of dependency, tolerance, or also side effects of the cognitive problems. But I think though, when we use in the carefully low dose and for the limited durations of time, it may be beneficial for us also. So this is the new meta-analysis of the comparative efficacy of benzodiazepine and antidepressants for psychic versus somatic symptoms of generalized anxiety disorder. This clinical experience also supported by this research evidence from a 2024 meta-analysis of 24 randomized control trial compared benzodiazepine and antidepressants using the Hamilton's anxiety, the psychic and somatic subscale. For somatic symptoms, benzodiazepines were significantly superior with weighted mean difference of 1.81 and p-value of 0.02. But for the psychic symptoms, benzodiazepines also show larger effects, but not statistically significant. The overall evidence quality was moderate, limited by heterogeneity and study bias. So the implications are clear. For patients with somatic predominant anxiety, short-term benzodiazepines may provide relief where other treatments fall short. The practical steps include assessing symptoms with Hamilton anxiety subscale. And then we have to documenting the indications for this particular situation, setting time limits and monitoring closely, because we know that the benzodiazepine use can be harmful also for the patients if we are not working very closely with this kind of things. Planning taper strategies, and maybe considering antidepressant plus short-term benzodiazepine can bridging when appropriate. So future needs, we need the guidelines, updates by symptoms type, larger pragmatic benzodiazepine trial. So this brings us to an important point. Guidelines are valuable. We know that we need guidelines. It's very crucial and important, but they are not absolute. Our patients remind us that flexibility, clinical judgment, and cultural adaptations are essential. Evidence must always be interpreted through the lens of patients' realities. So to conclude, I would emphasize 4 key messages. First, we have to prioritize patient outcomes, relieving symptoms and improving functions. It's the main of the patient's need. So embrace pragmatism, use all tools responsibly, including benzodiazepine when appropriate. Advocate for resources. We know in some countries like Indonesia, the need for psychotherapy, but the lack of psychotherapies, and the patients also, they don't support psychotherapy can be very meaningful, and the comprehensive services will be beneficial for these patients. And also share clinical wisdoms like we do now here, so that global psychiatry benefits from real-world insight. And so thank you for your kind attention, and I look forward to our discussion.
Thank you for the interesting talk, and we have no more questions, comments.
Yes.
Thank you for your nice presentation.
Thank you.
Can you say a little bit more about the usefulness of online psychotherapeutic interventions? Because I think they may have an advantage, maybe especially
Yeah. Since the pandemic, I think the online consultation, online psychotherapy has some increasing amount of patients also that cover that psychotherapy. In Indonesia, there are also some of the psychologists, colleagues of psychologists, they provide also the online consultation. But I think we have to be aware that sometimes most of my patients, I don't want to talk about other patients, but most of my patients, they reluctant to psychotherapy because it's quite a long period of time. They need a long period of time, and then sometimes they don't see any improvement in the first months of the therapy, and that's the point why many patients are reluctant to. But I think it's quite in the rural area, because we know that Indonesia is very big country, 17,000 islands, and then we know that it's a very benefit if we propose the psychotherapy, the online psychotherapy. But I think we need also very careful with that if there is no kind of like a supervisor for this kind of particular techniques. Thank you.
Yeah, thank you very much. Did you also assess side effects, like with the benzodiazepine therapy? What about the side effects? Of course, you have a reduction in anxiety, but what about adverse effects, maybe?
Yeah. We know that that's kind of like benzodiazepine use have side effects like drowsiness, but many of patients with somatic problems, they get help very much with like alprazolam, but the small doses of alprazolam. In our clinic, we just only need about 0.25 to 0.5 milligrams per day, not per once use, but. I think with the psychoeducations, like Professor Gao said, that we give the patients benzodiazepine together with the antidepressants, and we educate the patients with this kind of thing, like that this is benzodiazepine. It is a very relieving symptoms because you are very anxious, and then I will give you alprazolam, but maybe you have to reduce it after the antidepressants take effects. But sometimes, like the presentations I gave you this afternoon, some of the patients that given by the benzodiazepines, they are not completely, improved by the antidepressants alone. So they just need to get together, and then we know that we have to reduce the benzodiazepine after maybe about 2 months until 4 months. But most of the patients can reducing the need of benzodiazepines. Not only, we are afraid of dependency, but most of the patients are willing to let benzodiazepine off with the medication.
So you presented really nicely the efficiency and effectiveness of pharmacology, and as a prescribed therapy can take a long time and an arduous process. But the idea behind it is, of course, often that once you undergo therapy, you have overcome symptoms in the long run. And I was wondering what your concept is. Are you proposing a combination of pharmacology and therapy, rather, or a long-term treatment with the pharmacology until when? Yeah.
Some of the patients, they know that they need medications for the therapy, for the symptoms, for the relieving the symptoms. But we know also in Indonesia, the stigma is still there, even with the informations that gather from the internet. But still, stigma is still there. So they are still afraid of come to a psychiatrist, even using medication. Unfortunately, when other colleagues like internal medicines or kind of neurologists give them the benzodiazepines together with antidepressants, they don't complain. But when psychiatrists give them, they just feel, oh, I will be dependent with this medication. So maybe we have to set the time limit. So sometimes there's non-compliance. This is the problem with the medications also in Indonesia, the non-compliance. So there will be some of them are not willing to continue the medications. Just put off the medication after the symptoms relief, even though we educate the patient that you have to continue until maybe about 6 months until 12 months. That's the real thing.
Well, thank you very much.
Thank you very much. Thank you very much.